This podcast is for educational purposes only. The information presented is general in nature and is not medical advice, diagnosis, or treatment. Watching this video does not create a doctor-patient relationship with the hosts. Always consult a qualified healthcare professional regarding your individual condition before beginning any treatment or exercise program. If you are experiencing a medical emergency, seek immediate medical care. Hey everybody, and welcome back to the Two Bros and Some Joints podcast, where we talk about different kinds of aches and pains patients have, what options for them may exist. We break down some common myths, and then in general, we just chat about our own personal experiences in our private practices. Speaking of which, this is Dr. Nick Hunt, rehab chiropractor from Jacksonville, Florida, in private practice now for over 4 years at Arate Rehab Chiropractic. I am Dr. Austin Ehmke, rehab chiro from Omaha, Nebraska, in private practice now for 4 years as well over at Body Kinetics Rehab Sport and Spine. Dr. Nick and I, we graduated together from Palmer Chiropractic in Daytona Beach, Florida, with a mission of elevating the chiropractic field through an evidence-based approach, patient-first approach, all to musculoskeletal injuries. Throughout these episodes, our job is simple: help you guys better understand your body and some of the options you might have regarding your aches and pains. Today, a fun one. It's what we see all the time. It's super prevalent, low back pain, but specifically low back pain related to disc herniations. Nick, let's start off with one of the most obvious things. When a patient goes to a doctor, whether it's their general practitioner, their spine, their chiro, and the first thing that they pull up is their imaging. This is something we hear all the time. They're like, I don't know, my surgeon, he told me I got a disc herniation. I've got really bad disc degeneration. I don't know if there's a cure. Let's talk about it. Those are like the famous last words: disc degeneration or a disc herniation. At specific, I know they're not the same, but that's usually what they lead with. So they say, oh, I don't know, I've got this degeneration and I've got lots of herniations. Nick, how should we be approaching this with patients?
So the first thing is that many chiropractors, probably physical therapists and orthopedists, they likely have either this model on the counter or a poster on the wall that says levels of spinal degeneration. And so it shows you a normal, healthy spine, grade level 1 degeneration, level 2, and level 4, where you have this extreme osteoarthritic spine. There's essentially no disc space. The bone has osteophytes or bone spurs projecting down over top of it, and it just looks all gnarly and toothed up. And so the first thing that happens, oh, you've got this MRI that gives you this information that tells you you've got degeneration or a disc herniation. And so all of that stuff is literally just built into fear the diagnosis, and that is a horrible thing. Our job as providers is to instill hope that there's an answer. How do we work around this stuff? You're not broken. Blah blah blah. All these things. Versus, hey, you should be terrified of this. Do something now. It's like if that invites them to do something beneficial of it. I don't think fear is the best motivator to get real lasting results, because you're going to be worried about everything. Then you're going to be so afraid, if I don't do my exercises at home that my PT gave me, or if I don't go get surgery, I'm doomed. So that's the number one thing I want to address there, because that is you've seen it in practice. You've worked at offices before when we first got out into practice that were all fear mongering, and it's terrible.
Yeah.
I've seen it in all sorts of different types of practice. But when it comes to the image itself, whether it's talking about herniations or just degeneration, the thing that we need to know and understand is that that image is a singular picture in time that does not tell us anything about the functionality. And it also doesn't tell us why that pain is there.
Mm.
I actually just delivered a speech to this weekend, um, about why where does not equal why for pain. We
Yeah.
see these pictures and say, oh, you've got degeneration, or if you've got a disc herniation of different levels. Sometimes you can have just degeneration, you have a disc bulge, a disc herniation, a disc protrusion, all different levels of degeneration that are going through there. But your MRI doesn't put a little red sticky note and say, this is the one that's causing the pain.
Yeah.
They are trying to correlate these findings to the symptoms you're having. And sometimes that works. Sometimes they're right. Sometimes they're not.
Mhm.
And so what the research shows, so this study that I pulled from here pulled 33 articles, over 3,100 patients, all of which were asymptomatic, means they didn't have any pain. Typically, the pain associated with a disc herniation is radiculopathy, sciatica, pain going all the way down the back of your leg, numbness, tingling,
Mhm.
cold sensations, shooting pains, things like that. And so, the really key part to this study is all of them asymptomatic, no pain, no symptoms whatsoever.
Yep.
And
So
what
we
it
took
showed,
a bunch of pictures basically of healthy people. They just
of
rolled
healthy
in.
people.
They're like, "Hey, just lay down. We're gonna take some pictures of your back. We just want to check it out." And they're like, I don't have back problems." And they're like, "Cool. You're gonna pay me for my time? Sick. All right, get on the table. We're putting you through the big donut."
Exactly, the donut of truth. They put them in there, and uh, and so here's what they found: the prevalence of disc degeneration in asymptomatic individuals increased from 37% of 20-year-olds to 96% of 80-year-olds. So disc degeneration at 80 years old, it's a guarantee.
Yeah,
Even
it
at
basically
20
guaranteed.
years
Yeah,
old, you there's 37% of
it's
it. It's not zero,
more than 1 in 3, which is crazy to think about.
literally.
Right, and so
Over 1 in 3.
the majority of our patients, Nick, are probably between the ages of what, 30 to 50 that we see, 30 to 60.
Yeah, 30
So
to 60. Yeah, I'll give that range.
so we're talking about in terms of disc degeneration, we're talking about 52% up to 88%. Half of our
Mhm.
patients can have have multi-level disc degeneration, but have no pain associated with it. Now, we're not even talking about like a disc bulge or a disc protrusion. Those
Yes.
numbers
So that
land
part's
anywhere
next.
between like 40 to 70%, right? Like that's
So
insane numbers.
what I've got disc bulges prevalence from 30% of 20-year-olds to 84 at 80 years old.
Mhm.
So then we go to disc protrusion, a little bit more serious, supposedly. We have 29% at 20 years old. So just under 1 in 3 at 20 years old have disc protrusion with no symptoms, and 43% at age 80. And then the prevalence of annular fissure. This would be where the herniation, where the cross-hatching fibers around your disc have ruptured. And 19% of 20-year-olds, so 1 in 5, have that at 20 years old, and 29% at 80 years
Yeah.
old. So this is telling us all something very, very interesting that we should all take note of. When we get these images, it is not a guarantee of this is the thing causing the pain. And this is where most orthopedists, chiropractors, physical therapists, all these medical professionals put so much weight on the image itself, rather than looking at how is it presenting. The last thing that goes in any radiology report that we've ever received is correlate with clinical findings.
Yeah.
And most providers end up taking that MRI as law and says,
Yeah.
disc herniation, there's your pain, that's
Yeah.
it. When this is clearly showing that significant percentages have zero pain, zero symptoms, but still have those findings on this.
Well,
Um,
and it tells us even a better story too. Is was that there before? Because you could go in and you could have pain in the area now, and you could say, "Oh, well, it's because of this. It's all when you were bending over. That's what herniated that disc right there. When you were bending over to pick up your sod, you cut a new section of sod for your lawn because your dog keeps peeing in one spot." Personal story. Uh, and you want to replace the sod. It's like, oh, when you threw your back out, it's like, that's when I popped that disc herniation. It's like, no, it's probably been there for like 2 or 3 decades. You likely irritated the surrounding area, and we don't even know. Like, does it have neurological components to it? Did your orthopedist, did your PT, did your chiro, did they actually go through a full neuro and MRS testing and orthopedic testing? If they did, fantastic. That's great. I love them for that. That's what they should be doing. Or did they just specifically take some imaging, pumped it through, and went, I don't know. It must be this that's causing it. However, when you correlate the findings across, clinically, it doesn't make any sense because that's usually what ends up happening. And that is unfortunate because now all of a sudden this patient now believes Oh, that's what caused it. It's that one specific instance when I bent over to tie my shoes that did. It's like, no, it's probably been there for like 3 decades. You just irritated an area, or you may have irritated a supporting structure. What we see, right? We see joint sprains, we see muscular strains take place, and that's really what the actual issue is. Is the imaging says one thing. You put it perfectly. It's a singular image in time, and it doesn't tell us anything about this person's function, because if I immediately start to challenge, okay, when's the last time you've been to the gym, George? And they're like, oh, I don't know, like 20 years ago. It's like, okay, well, you're incredibly deconditioned. You decided to go do 5 hours of yard work today because you absolutely needed to, and you haven't done that in 20 years. What part of that sounded like a good idea? Like, if I put it on paper, that makes more sense. But when initially in a patient's mind, and this is the hard part, it's not the patient's fault. It's not their job to think that way. That's our job to think that way, and our job to explain that to them. Why? Okay, this is probably what happened. You probably didn't just destroy. You didn't destroy your entire lumbar spine. You don't have multi-level lumbar facet arthrosis and L4, L5, L5S1 spondylolisthesis with multi-level disc bulges just because you bent over to pick up a roll of sod one time. That's not how that works.
Now, and this excludes, like, traumatic injury. You were in a car accident.
Yes.
Totally different scenario.
Yes.
This
God,
excludes
yeah.
that I wanna hit on there.
Yeah.
And then I'm gonna push back just a second on what you said there just a couple of seconds ago. Um, you likely had this thing for decades. What does the research say about spontaneous resorption? You
Yeah.
know, how long does this take? How long, if you injure your back, if you have a disc herniation, how long are you actually going to have that disc herniation? I hear people all the time sit there and say, I herniated a disc, 4 or 5 years ago, and so that's still giving me problems today. Talk about that. What have you seen with that?
So in general, the most accepted range is about 70 to 90% of patients with a lumbar disc herniation and sciatica. They will typically improve with conservative care. Now, that's not even talking about the disc herniation itself. The disc herniation itself, it was the most recent systematic review and meta-analysis was in 2020. They had actually looked at over like 2,200 patients. About 63% of those patients, which is more than half. It's not all, which is still a good number. It's enough to pay attention to. They had some measurable regression of the herniated disc on a follow-up MRI following non-surgical treatments. Only non-surgical treatments were the ones that were measured. So if you just went home, you listened to your physical therapist, you listened to your rehab chiropractor, you listened to your chiropractor, you listened to the orthopedist, but you didn't do surgery, 63% of them had regression, meaning the actual disc herniation itself improved. It looked better than the first one. So the first one looked like shit, and the second one looked like, well, not quite Mona Lisa, but it was better. We were getting there. It was shit with sprinkles. It looked better. Effectively, you improved by just doing what you were told from a conservative method. So and of course there's nuance to this, right? Sequestrations and extrusions, they have a higher probability of regression rather than a protrusion or a bulge. So there's variance there. However, it can improve. So for somebody to say, oh, 5 years later, it's still the same thing that's bothering you, it's like, I don't quite think that's statistically, it probably isn't actually. And if you are if you are that small percent, if you're a 13%er, it's like, go buy a lottery ticket while you're at it. You're probably like one of those weird, you're the second or third confidence interval removed when it's like, okay, you're probably the weird oddball out. That's like, yeah, it sucks. I'm sorry. But when every single patient you seem to run into says that's the same, it's like, that's probably not the thing. Who's telling you that?
Yeah, it's probably not the thing. And like you said, if I'd go buy that lottery ticket right away, because if I was a betting man, I would bet that it is not the same disc herniation, the same
Right.
issue going on. So as we're talking about that, follow through with conservative care, regardless of that, because of the prevalence of asymptomatic people having this, that also can mean that we can reduce symptoms without reducing what the findings on the imaging is.
Yeah.
Would that be correct? That's a fair thought, right?
Yeah.
It's not what
And that's
necessarily
what the
research
statistics
talks about,
says.
but
Yeah. I mean, the other, if I'm doing math right, 37% of people 37% of the other measured non-surgical treatment alone had no regression, meaning their symptoms got better, but they didn't have any regression. So their symptoms got better, but structurally it looked identical, or at least close enough identically on an MRI that when the radiologists read it, they're like, this looks
There's
really
really no
similar.
difference.
I can't really
It
tell.
looks like the exact
I'm
same
not
thing.
willing to
Yeah.
say, yeah, that it was different. So, that says a ton right there. Is like, look, your symptoms improved, but the structure was the structure maybe causing the problem? Maybe, I don't know. At this point, I can't call it causative. It's
Yeah, you
purely
can correlate the two.
correlative at this
Yes.
point.
And to that extent, what the way that I see this clinically is a lot of people look to call that disc herniation the causative factor rather than a correlative factor. They say this is the thing causing your pain. And I would stretch through my experience to call that disc herniation a symptom rather than the cause of the pain. So what that disc herniation may be putting pressure on the nerve, may be causing irritation through there, giving you sciatica. But if the symptoms will heal and get better without a structural healing of that disc, then we can't say that that disc is causing it, because if that were true, then you'd still have pain. And up to 37%, like you said, have no improvement on image, but have significant improvement in symptoms. So it would make me think that the disc itself having herniation or bulge is more of a symptom of structural instability, load management through the spine, as we often like to talk about, creating and enhancing load management for regression of symptoms. That disc is a symptom rather than a
Mm,
causative agent for a
mm.
lot of these patients. Not all, but a
But a
lot.
lot, yeah. So let's tangent for a second too, and let's say, Nick, you are that person that does inevitably, if you hit some of the red flags, and obviously never to try and suggest what somebody should or shouldn't do. Always talk with your medical provider first. However, if you're somebody experiencing red flags of disc herniations, or what we call, like, what's called cauda equina syndrome, you've got tingling and numbness down both legs, what's called saddle anesthesia, paresthesia, where in between the legs you're having um, no sensation or diminished sensation. You're having
Particularly in the
muscular,
groin.
yes, you're having motor weakness within those. You're having a drop foot gait. You have you have the scariest of all of them, which is bowel and bladder incontinence. Those are all red flags. Those are cases where, fortunately, you and I, we don't run into those. People go to the emergency department, they get those things fixed, and that is where the surgeons shine. They do their job, they fix the herniation, they fix what's hitting specifically the spinal cord and its rootlets, and they fix the problem. It's fantastic. And in fact, even what's super cool is, and this is where I will always, throw the shining bone to my surgeons that I've worked with. My wife even works for a surgical center that is specific for pain and spine. They've done they've done measurements in longitudinal studies from the operative versus non-operative in 4-year and 8-year outcomes. And this is specifically with patients who have gone through conservative methods. They've tried all the strengthening, they've tried all the rehab, they've tried all the injections, they've done all the things, and they failed all of those. And then they went and they did what's called like a microdiscectomy. Believe it or not, those actually do really, really well. And I'm happy to say that too. It's like, wait a sec, the rehab guys are saying surgery is good. It's like, well, yeah, if surgery works and then it works 4 years after, and then it works 8 years after, it's like, that's kick ass. That's cool. That's where the
No,
surgeons shine. They're doing their job so damn well that they don't even have to go back and help it 8 years later. That's killer. Like, can I buy them a
that's
round of
what we
freaking
want,
beers? Like, that's sick.
dude. Yeah, that is
But
ideal outcome. If you have to get surgery, we want that to work. If
yeah,
that becomes the last option, and none of these other things have worked, we want that last option, our final choice there, to be the thing that works. If
yeah,
nothing else has, then we want that to be successful.
yeah.
We're not sitting here rooting against surgeons.
No,
That's not what we're doing.
no,
Everything has a time and a place, and when the other things don't get you where you need to be,
yeah.
you have to make that call of like, I do have to go through this, and
It's
then
there
we
for a
hope
reason.
and pray that everything goes in favor of you in that place, that
Yeah,
they do what they need to do and you get the outcomes you're looking for. And
yes.
sometimes that is the case.
Yeah, and what's funny is just like later we're gonna have we actually have two people lined up to come onto the show already. One of them is in spine and pain management. The other one's a spine surgeon, and it's like I love what they do. And they'll even tell you they are actually they're really nitpicky about who they do and do not treat, which is what I think probably makes them amazing at what they do. Is they are very cautious, they're very careful. They make sure a patient has completely exhausted, and I mean like exhausted every choice before ever going into that round. But what it says is like, hey, when they do exhaust it, when they do it correctly, their outcomes are kick ass, which is sick to hear. That's awesome. That's what we want, because at the end of the day, we're in this for our patients, and so are they. We want you to feel better. But it's really cool to hear. It's like not only will the conservative methods work, but when if that does fail, which is the greater majority, 70 to 90% of them will do better with just the conservative methods. Even if you're the 30 to 10% that has to do this route even kicks ass too. That's really good. That's fantastic to hear. So I guess what we're saying in short is like, if you are one of those patients that has to go either route, it's like you're kind of set up to win. Like, we've gotten really good at this. Can we get better at it? Yes. But we've gotten really good at this from both sides, from the operative and non-operative. We've gotten really good at treating these, which is, as if you're a patient or if you're somebody who's struggling with these things, listening to this is like, that's awesome for you guys. Like, you guys are really getting set up for success. We've gotten really good at treating these things. We need to get better at them because there's always more we can learn. There's better methods we can learn. But I think in short, what the data says is like, if it doesn't resolve on its own with conservative methods, there's a pretty good likelihood it's going to resolve with surgery too, which should make patients feel a lot more confident, a lot better about like, hey, this sucks. I have this, but it's like, we will probably figure out the solution for this. I promise.
Well, and the thing about that too is that's the people, a specific population who has gone down the path. They've done physical therapy, they've talked to a rehab chiropractor, or even just a traditional chiropractor, and they've done those things and exhausted those methods because one of the research articles that I found here is almost 5,800 patients per cohort for this. And with chiropractic spinal manipulation therapy, the adjustment, um, it compared to those who needed to have that microdiscectomy surgery post treatment. And let's see, where does the thing go? Um, so what it shows me, receiving compared with those receiving other forms of care, and this is
Mm-hmm.
just about the adjustment too. This is not including rehab and things like that. Significantly lowered the amount of people at 1 year and 2 year follow-ups that needed to have that microdiscectomy.
Mm-hmm.
Um, of let's see, uh, 2 year follow-up, 77%
Yeah.
did not need to get, if they were receiving spinal manipulative therapy, just the adjustment compared to other therapies, it improved. 77% did not have to go through the microdiscectomy. So it
Well,
tells you this stuff is what you do first. This stuff is how you try and manage this stuff first. And the research shows that. But if you are in that select population that it doesn't quite get you where you want to be, that's when we take the next step and go to the next part in line.
yeah. And what's nice is it's not like it's like, oh no, this is a last ditch effort. It's like, no, they've gotten so good at this. Like, at the 4 year and 8 year outcomes, if you're having to have those things for a disc herniation, look how good they are at it. Like, these dudes kick ass. Like, those
Mhm.
gents and ladies, they are kicking ass at it. They are so good at it, and that's a good thing. But
Now,
every and
I
no,
want to
not
bring
every
this up.
patient wants to have surgery, and but it feels good being able to look at it now and say, okay, cool. Even if we fail at this initial part, it's not the end of the world. What's really nice is, look, I got this, bro. I've got this lady down the road. They are totally gonna hook you up, and I 4 and 8 years from now, we have the evidence to say you're probably gonna be just fine. And I know that it
Right.
sucks, but this just may be a case that you have to do that. So I guess what we're saying is like, either way, as somebody who might have a disc herniation, you're pretty much set up for success. Like, they have gotten so good at this on both sides. The conservative and operative means we have gotten so good at this. You're kind of set up to win, like, which is sick for them.
Now, I do want to talk about this because this is a personal experience that I have had with this in treating patients here. I had a patient um, who was high school and collegiate volleyball player. In high school, she had a disc herniation. Um, Went to the orthopedist. They got the MRI. Said disc herniation. We need to do surgery to go do this so that way you can go back to playing and do this. It'll be great.
Yeah.
She goes through with the microdiscectomy
Mm,
at 17 years old,
mm,
and they say no physical therapy needed, no nothing. You're young, you'll bounce back quick.
ugh,
They shrug it off and say, okay. So she goes on, goes
mistake
to
number
place
one.
college, does it again, has a second, goes to another orthopedist, has a second microdiscectomy. And now you and I both know, looking at this stuff, what a microdiscectomy is they go through and basically you have the two end plates of your vertebral bodies, and then your disc goes in between. They basically go through and shave off the herniated part. And so there's less disc material there afterwards. They had done this to her twice. And then a few years later, she's a nurse and moving patients from bed to bed on her feet all day, 12-hour shifts, and she gets the same symptoms coming back.
Hmm.
These are a couple years in between each one, so it worked for a time. And then she had gone to chiropractors and trying to manage some things, done some physical therapy, wasn't quite getting it. She got to the point where she was working on the floor and could not feel her foot whatsoever, couldn't lift, everything was too painful, could barely put her shoes on. And then she got referred over to me.
Hmm.
Um, Luckily, over a course of treatment, we were actually able to get the symptoms to regress because she had had a another consult because she thought, I guess I have to go talk to the orthopedist again. And the next step, because they can only shave away so much of that disc before there's nothing left.
Right.
Um, the next step was going to be a fusion,
Right.
cervical spinal fusion.
Yeah.
And she wanted to avoid that. And she came to see me, and over the course of treatment, we were able to get that stuff back. So the quality of the care that you're getting does matter. We were able to do that for her, and I thank God for that because that was a legitimate last ditch effort to saying, I don't want to have a fusion. I want to be able to move. I want to be able to do this stuff. I don't want to be, you know, set up to where in 20 years I have to go get a revision on this thing because it just wears down.
Yeah.
Um, and so that's an example where they probably jumped into surgery too soon.
Yeah.
They jumped to that conclusion first rather than trying the other things first that could have prevented the second surgery or even the first surgery. And versus, having to come to me after having two surgeries that worked for
Mm,
a little bit, but ultimately left her in the same situation, which again talks about different things that we've already touched on. Is that disc actually the problem,
yeah.
or are they shaving away something that they think is going to help and it helps for a period of time, but other problems that mimic the same thing
Mhm.
are going on, and that disc might be a symptom of improper load management for day-to-day activities and working out and your work duties, that it's showing up as a disc herniation as a symptom rather than the causative factor. So that symptom goes away, you feel better for a time, but then it comes back
Yep.
even after two surgeries. So I do want to highlight that. And
Yep.
if they jump to surgery first without saying, I need you to try this other stuff first, because while we are good at what we do in surgery, they are good at that. It might not be the right answer. They might
Right.
not be fixing the right problem. And
Right. And
that is something to
that's
really think about.
yeah. And that's where a lot of times too we ask ourselves, especially whenever we see a lot of literature coming through, is the first thing that we have to ask ourselves about any sort of surgery is, did the surgery do what it was intended? Did it actually work? Or did we just potentially deload the patient and then properly reintroduce load to them over a specific amount of time? What we call like proper load management. I know you mentioned it a few minutes ago. Is did you just do that, which is glorified load management? Did you just effectively pull the patient and give them an excuse to properly reload, retrain, and condition a deconditioned structure properly? The hard part is neither side can actually agree or disagree on that. We have no evidence to say one way or the other. However, when we see evidence existing of things like what you just said, where we have patient populations who have disc degenerate, multi-level disc degeneration, facet arthropathy. We've got multi-level disc bulges, but they have no pain. If I go in there and we do some rehab with them, it doesn't, those structures don't necessarily get better, but the patient improves. Similar to that, if one of my friends from the spine center cuts off a portion of the disc herniation and they get better, which was it that caused it? The problem at the end of the day, neither of us necessarily know. We don't have an answer for it. However, one is a lot more intrusive than the other. Nothing against my friend over there. He's a great dude. He's an awesome guy. I love what he does. He's incredibly evidence-based. He's very conservative approached. But neither of us can actually tell you which maybe did or didn't completely resolve the issue. And I think that's the hard part is we have to always start with the conservative method first. And he'll say this, and he says this to all of his patients. He's famous for saying it now at this point in their clinic was, I'll always be here, at least for the next 20-something years before I retire. Surgery will always be on the table. I'll always be here for it. But if you decide that you want to have it early, I can't go back and undo what I did. But if you work from the conservative method, you can try lots of different routes. There are lots of different approaches to how we do things from the conservative side. And he's famous within the clinic of saying is like, use me last. I want to be the break glass exclusion. Like that's the way we need to use that. And again, it's no dig to them, but it's what the evidence suggests is that you need to exhaust all your other options first. But the nice part is even at that point is once you've completely exhausted the options, because it sounds like this person really didn't necessarily go through that route. They didn't exhaust their options. And I mean exhaust them. I don't mean going once for 6 weeks. I mean, you exhaust the hell out of your options. You look at it from different options, from the physical therapist, from the chiropractor. You go and you work. Is your body actually deconditioned? And you're asking a lot of it. We see this it's actually about time for the fall leagues to start up here for golf. And I'm sure that I'm going to get some low back pain patients because you got some patients who maybe they joined like a summer league for golf and they only golfed like the first 9 or something, and then they're going to go golf this second league, and they have to do a full 18, and they haven't swung clubs for 18 holes in a year, and it's like, oh, well, it wasn't this disc herniation that's been there for 2 decades, like we talked about earlier. It's the fact that you're like incredibly deconditioned, Mr. Smith. You just tried to up your load 2x, and you never practiced that. Where in the world do you think that idea would be great? That's like deciding to go from like a 200-pound to a 400-pound bench press. That's probably not going to go well. I don't know why that's the same.
Well for you.
Yeah.
Yeah. Well, it's what you and I say all the time. It's too much too soon after too long, or too little for too long.
Yeah.
And that's exactly the perfect descriptor of that stuff. You know, you haven't played, and then you're going to decide, I'm going to go play 2 rounds of 18 today. I'm going to do 36 holes in this tournament here. I'm going to do this, and it's like you're going to fall apart, dude. You went from nothing to everything plus some more. It's like, why did we expect that to go?
Your statistical risk of injury is so incredibly high. Like if you make it out of it, that's great. I'm happy for you. I don't want you to get hurt. Statistically speaking, though, you're probably going to get hurt. That's just how that works.
Yeah. But if you're active and you're doing things with it, and it's like, okay, this is just a different type of activity. It's like, awesome. We're going to be able to handle this.
Yeah.
Because I'm used to being active. I'm used to doing this. I do this every single day. So, going and playing that 18 is like, that was actually a deload compared to, someone who's like, I do CrossFit and I do this, I do that. I train for 2 hours a day and I do this. It's like, yeah, this is just relaxing. A different form. Yeah. It's going to be easy.
It'll be easy for him. It'll be fun. It'll be fun versus the other person who's struggling. And I think that's probably a good way to even like round it up is like, if you are struggling with a disc herniation, there are so many options that exist. And the cool part is at this point in time, even from the non-operative to the operative side, the options that exist are fantastic. But I think the most important part is like finding somebody that matches your goals, because you just described it perfectly. I don't know if you meant to or not to like throw me that fucking softball of a like transition. That was great. Are you this CrossFitter, or are you this person who only golfs maybe 9 or 18 on the weekend? Who are you? Make sure that you match with a provider, whether they're a PT, a chiro, a trainer, an ortho. Make sure you match with somebody that understands and meets your needs and goals. Because if they don't understand your goals, if they don't understand where you want to go, you're probably not going to get the outcomes you're looking for. And that's where failed conservative care happens. That's where failed surgical care happens. Did we actually meet the patient's goals? Were we doing what the patient actually wanted and expected and got the results and outcomes they wanted? If not, then you need to make sure you match it. And it's not that you need to like base it off of the fact that it's like, oh, well, I don't know, Nick's got a killer beard, so I'm going to work with him. It's like, yes, he's got a killer beard. However, did he ask you about your goals? Like, did he ask you like, What do you actually want to do here? Because if not, then I don't think that that's going to be a good match for you. But if your only desire is to get out of pain, then sure, that's fine. Then a lot of people will do that for you.
Right, and then, you can always sit there and say, like, if your goal is to sit on the couch without pains, like, Advil works really, really well.
It
Uh,
does.
one more concept I wanna or topic I wanna talk
Yeah.
to you about before we, finish up here.
Yep.
Let's dive into some specifics. What types of treatment, not necessarily just the providers that you want to talk to and making sure that they are aligned with your goals and what you actually
Yep.
want to get out of it at the end of it. What kind of techniques, what kind of rehab methods would you say are the best to handle this kind of stuff, a lumbar disc herniation with radiculopathy?
Yeah. There's a, and this is the tough part, right? Is there's a lot that comes with it. The first thing that at least like we do in our clinic is a neuro and MRS testing. If it's indicated, then perfect, cool. If it's like, hey, yeah, I'm having tingling numbness down the side, it's following a specific dermatome. Let's get the classic L5S1. It's going down into the foot. It's like sick, cool. This is very straightforward. What this is, it's a unilateral disc herniation. Probability is pretty high at this point. I don't need imaging to tell me different. My neuro and MRS and reflex testing is telling me all those things. One of the first things that they're probably going to have is an intolerance to a specific side. They probably have a side that they have relief to. They probably have a side that they have intolerance to. The first is, okay, this is great. However, can I get this to be more comfortable so that I can push into this a little bit more? There are things like McKenzie extension protocols. There are things like spinal manipulative therapy that can all help with this. So, like manipulation and mobilization. We have evidence that that helps. Does it help more than others? Certain evidence says yes. The part that's really hard to find, though, and I think this is where we were going earlier that we were talking about, was there isn't evidence that suggests a manipulative therapy plus like an exercise therapy together. They always pit them against each other. But even in clinic, what do we see? We see is like if we do this plus this, we get like crazy good results. Is that what you're asking? Because that's
Oh
predominantly
yeah,
like
yeah.
like that's where I'll sit is like and even more specifically, I guess, is if that patient has an experience with chiropractic. If they're like, oh yeah, like the last time this happened that did really good, it's like, okay, that's great, but it came back. So the spinal manipulative therapy was helping in terms of calming symptoms, but we didn't fix the other rest of the problem. We didn't fix your deconditioning. We didn't fix your tolerance or intolerance to specific movements. So we can use the SMT to actually cool this thing down. However, we need to do more behind it.
No, absolutely. I couldn't agree more with you. And the first point that you made is talking about how do you present? Okay, we know what your MRI finding says. You are telling me that you have sciatica that's going down the foot, and we follow it on that L5S1 dermatome pattern. So we see these things, and then we will take you through that functional movement assessment. You're testing and you're seeing, okay, are you flexion intolerant, meaning that when you bend forward, it flares it up, or you
Yeah,
extension intolerant. When you lean backwards, does that flare it up? But you can bend down, put your shoes on, no problem.
right.
So how these things present is totally different because where it's harder to go is usually where I'm going to start looking at and starting feeding more into. Okay, if we can't go into flexion, we have to learn and figure out how to make you go back into flexion again. And there are tons and tons of different ways, like you said, the options are literally endless about things that could help. But what I want to bring to the attention here for this before we wrap up is this study that I found. It basically throws these types of treatments into different levels, level A, B, C, or D on levels of effectiveness. But it doesn't say exactly how they're presenting. It talks about patients with lumbar disc herniation confirmed on MRI with radiculopathy symptoms. So it doesn't say how they're presenting flexion intolerance, extension intolerance, lateral bend. Is it one leg, both legs? Doesn't really talk about that. But what it does say is it puts several of these treatments into. It actually doesn't list anything as significant evidence that it works.
Mhm.
Puts it gives starts off with level B, so moderate evidence of effectiveness. So showing that it does work, but if we don't actually have any A tiers, this is actually the best that you can be doing,
Mhm.
which gives us the level of effectiveness for conservative treatment. Patient education, self management, McKenzie method, like you had talked about, mobilization manipulation,
Mhm.
which would be the spinal manipulative therapy,
Yep.
exercise therapy, traction, but only for short term goals. So when you go
Mhm.
to a chiropractor and they say, we've got this fancy table that it basically just tries to pull you apart,
My
uh,
favorite.
eh, it only works for a short amount of time, no
Yeah.
matter what they're telling you and selling you on. You're
Yeah.
going to go for 17 sessions of traction and you'll have the same thing in a year because these studies show that long-term effects, it does not
Yeah.
work well. So for
Yeah.
short-term outcomes, it actually tells you that this works really well. And then the last one on grade B, level B, it says epidural injections. Um, it identified weak evidence for two of them for saying traction for long-term outcomes and dry needling. Now, what this stuff is saying is not saying that
Is this the
these
same one
methods
that
are
did laser
bad.
too?
Yes, we'll
Yeah.
talk about that in a second.
My
But
favorite.
what I want to say is that it's not saying that these are just bad treatments that you
Okay.
should never do. It's that these just don't work for that,
Yeah.
for this specific diagnosis. When you have
Yeah.
these things present, this type of treatment does not show to be effective for that diagnosis. It doesn't mean it's not effective for something else.
Right.
Dry
Right. Right.
needling has been a fan favorite of mine for stuff like tennis elbow, lateral epicondylitis, golfer's elbow, medial epicondylitis, things like that.
The itis.
Dry needling I've seen to be very, very
Got the
helpful.
itis.
Um, got the itis. Um, However, it's about how and when you're using them. I'll say it a million times throughout these episodes. It's got to be the right treatment for the right problem at the right time.
Yeah.
If those things don't match up, that tried and approach doesn't fit, you're probably not going to get the outcome you're looking for. Because if you got back pain when you're squatting, I'm not going to max you out because that's the wrong treatment for the wrong time at the wrong level. So it's like it's
Yeah.
just not going to work.
Mm.
Versus later on with it, we might be able to actually get what we're looking at there. And then the final thing showed level D, uh, which showed no effectiveness or even conflicting evidence, meaning patients got worse. Electrodiagnostic based management, laser and ultrasound, and electrotherapy. So that's every old school chiropractor's favorite things to do to
Shock them.
throw a little bit extra money for it.
Shock the hell out
We're
of them.
going to put you on E-stim, shine a red laser at you, ultrasound, and put your stim on you.
I've got
They
this
show
car battery.
no
It's really
effectiveness.
good. I've got this car
Yeah,
battery. We're
literally.
gonna attach you to it. It's super freaking useful.
It's like
Yeah.
you're gonna tell us everything you know, but you're not gonna get better. It's fine.
This is not. We are not wanting you to interrogate your patients. So the
Yeah,
intake
no,
form is for.
definitely not. Definitely not. But again, it's not saying that those are inherently bad. It's that they're not good for this.
Yeah.
And so I
Yeah.
wanted to highlight some of that before we finish up.
Yeah, and those are different things patients are going to run into anyways. They're going to be like, I don't know, it helped kind of. My favorite is when it's like, oh, how was that? Like, you worked with a different person. Like, what'd you guys do? If the opening line is well, they were nice. I know immediately. I kind of smile, and hopefully my face doesn't say it all the time, but I think my face does. Is okay? They were nice to you. I hope they were freaking nice to you. They're a provider. I hope to God that they were nice to you. But did what I'm asking is did what they do worked? And if your answer is no, is I understand you're trying to mitigate the fact that you don't want to say something poorly about somebody else, but it means that not everything works for everybody. And that's where if you've gone to places where it feels like everybody is the all-in-one one size fits all cookie cutter approach, it's probably not going to work for everybody. And in fact, we have evidence
Mhm.
that shows that it doesn't work for everybody. Just like that, it's like, look, if that is the most tried and true practice of chiropractors or PTs or whatever, that's what they do, look, it doesn't work. And we have evidence that it doesn't work specifically for disc herniation. So therefore, we probably should stop doing it, or should at least tell our patients that, hey, this probably isn't going to work. However, it's a way that we might be able to mitigate symptoms. Yeah, it's good. So for patients, they have this laundry list of options. They really do. And so if you are somebody who's struggling with something like that, it's a good sign. You have options. You have options that work. We have stuff that doesn't clearly work, so you can start to cross stuff off. So we're already halfway through the process of guess who of what treatments might work for us. This is great, and then we even know at the end of the road if the conservative methods don't work, the surgical methods are working right now. But we also have to be careful about jumping into them too fast, too soon. There's so much nuance that goes into here. So at the end of the day, if you are somebody who's struggling with this, there's so much nuance that goes behind it. Is always talk with your providers, but make sure that they understand. Make sure that they're listening to, like, Are they readying you? Are they preparing you for the results that you want and the goals that you want? If the needle isn't moving that direction, then it might be time to move on. You might have to find another place that better understands you. But there are options. There's so many dang options here. We talked for 45 minutes about the options here. So you have options. Just make sure that you're focused on your goals the whole time. There are so many options for a disc herniation at this point in time, especially lumbar disc herniations. They're there. The evidence keeps getting better for a lot of them and worse for others. So sorry if you're on the losing end of that. We're not on the losing end of it, which is nice. As chiropractors, you do a lot of rehab. The evidence keeps suggesting, hey, keep doing that. Those are good things. Fantastic. So any closing words here? I think we've said enough about it. I like it. There's
No,
not really
I
much more
think
I can
we've hit
think
every
of.
point. I think that we've hit it all great. And, don't necessarily look for a specific person who does one specific treatment, because if you walk in and say I want this thing, and they could sit there and say yeah, absolutely, you can get that thing, that doesn't mean that one thing is going to help you.
Yeah,
Dry needling might not be the best answer, even though you saw online and you said somewhere someone told you that was the best thing ever. So you're looking for someone who does dry needling. It might not be the right answer for you,
right.
even though it's what you want. You also need to have the conversation with the provider of what is the best possible treatment that I could get, and how would we approach this in order
Yeah.
to get the best results, because the treatment, and how you approach it will drive the results, rather than throwing random treatments at it hoping that we get it right.
Pocket sand. Don't go
Yep.
to a place that pocket sands you, please. There's a King of the Hill reference. We're gonna make at least one every session. Yeah, don't go to somebody if that's the only thing that they're doing. I mean it in the best way possible. They should be wanting what you want. Yeah, if you are somebody who's struggling with that, talk to your provider. Know that there are options out there. There are lots of them that exist, but definitely poke and prod and ask more questions than what you feel comfortable asking. Ask more, because there's plenty of options that exist, and you probably haven't exhausted all of the options that exist there yet. All right. Well, next week we're gonna leave it for a surprise. We're gonna be recording another one here every single week. We're gonna be pumping out more and more content. If you want to hear more of this, make sure you hit a follow, turn on the notification bell, and we'll see you guys on the other side. Peace. If you've made it this far, chances are you care about moving better, training harder, or finally getting rid of an injury that's been holding you back. If that's you, we've put everything you need in the description below. Our podcast, social channels, free resources, and even a way to see if body kinetics or RTA is the right fit for you. And if you learned something today, send this episode to someone who's still being told to stop lifting, stop running, or just live with the pain. It might be exactly what they need to hear. Thanks for listening, and remember, keep moving, keep lifting, keep asking better questions, and we'll see you next week.